Good evening, everyone. I'd like to welcome everyone to tonight's General Club meeting. My name is Dr. Wardha Shabbir, and I will be serving as a club advisor moderating tonight's General Club meeting. So I am currently a family medicine resident third year, and I've applied to sports medicine fellowship. I find out January 8th, fingers crossed, and currently I'm going through the interview process. I am originally from Toronto, so if my Canadian accent comes out here and there, please excuse that. So the goal of the AMSSM Journal Club is to provide a national platform for student and resident members to present an article from the list of the top 120 articles that sports medicine fellows should be familiar with. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. We will have 3 presentations tonight. The format of the Journal Club meeting is that each presenter will have approximately a 20-minute block of time that includes a brief Q&A segment after the presentation. Throughout the presentation, you can enter your questions using the chat function, and during the Q&A, I will read each question entered into the chat and ask the presenter and their club mentor to respond. So let's introduce the first presenter. I am pleased to introduce our first presenter tonight, Dr. Nathan Michalak and his club mentor, Dr. Justin Mark Young. Dr. Michalak will be making the first 2 presentations tonight. Dr. Michalak is a dedicated PGY3 PM&R resident at the New York Medical College Metropolitan Hospital with a focus on sports medicine. Originally matching into general surgery at Columbia, Nate transitioned to PM&R after realizing it better aligned with his passion for restoring function and enhancing performance. A former athlete himself and exercise enthusiast, he's committed to improving physical and mental well-being through musculoskeletal care. Nate actively engages in the field by volunteering with Adaptive Sports Organization, providing sideline coverage and leading ultrasound workshops. He also holds leadership roles in professional societies and contributes to research aiming to advance sports medicine through innovative educational resources and community development. His presentation is on the article, Athletic Injuries of the Wrist and Hand, Part 1, Traumatic Injuries of the Wrist. I'll also like to thank Dr. Justin Mark Young for serving as his club mentor. Dr. Young is a native of Honolulu, Hawaii. He works for Hawaii Pacific Health at the Straw Bone and Joint Center and at the University of Hawaii Athletics as a team physician. As a core faculty member for the University of Hawaii Sports Medicine Fellowship Program, he enjoys teaching the sports medicine fellows, family medicine residents, and medical students. He is also the current faculty champion for the University of Hawaii Medical Student Interest Group through the AMSSM. During his free time, he enjoys hiking, kayaking, fishing, and searching for the perfect bowl of ramen. And now I'll turn it over to Dr. Michalak.
All right, thanks, Dr. Shabbir. Thanks for the introduction. Hello, everyone. I'm going to share my screen. I have a lot of content to get through. These articles are pretty dense. So I'm going to go pretty quick. I'll spend more time on like the more relevant stuff and then kind of refer you to the article for the less common injuries. And so I will be doing parts 1 and 2 on this topic. This is published by Arthur Rettig, I believe in 2003 and then 2004. Part 1, this is just traumatic injuries of the wrist. So that's where I'll start. Second. All right, so the learning objectives for the traumatic injuries of the hand and wrist is to understand the epidemiology, mechanism of injury, workup diagnosis, treatment options, and return to play guidelines for these injuries. So they are common, 3 to 9%, and can be, there's this one study here that quotes 8.7% in Olympic athletes, but of course, collision and contact sports have a higher incidence, and a lot of the injuries are sport specific. So you can anticipate certain injuries to happen in certain sports. I show you this right here, just to give you an overview of what the normal range of motion of the wrist is, because the range of motion is actually really important for a lot of different sports, and people have looked at how much range of motion is needed for certain things, like shooting a basketball, throwing a baseball, and a golf swing. I'm not going to read all these for you, but just pause here for a second so you can look and see, how much arc is needed in flexion extension, how much radial and ulnar deviation is needed for these movements. So the first injury that I'll talk about is a scaphoid fracture. This is very common. One of the reasons why it's easily fractured is because there's tenuous blood supply. This provided from one of the branches of the radial artery, and it provides 80% of the scaphoid via retrograde blood flow. This is kind of what it looks like, and this is important when we're looking at the location of the fracture. So just to touch on the mechanism of injury, this is one of the Fuchs injuries, fall on an outstretched hand, that can happen. And depending on how the impact happens, you can get different types of injury patterns. So the most important thing is that if you have radial-sided wrist pain in a contact sport, you should think scaphoid fracture until proven otherwise. So one of the tests that we commonly do is this tenderness to palpation of the anatomic snuff box. It's bordered by the first and third extensor compartments of the wrist. And you'll just palpate there. You should feel some tenderness. Now, the x-rays are often normal initially. So MRI would be your preferred modality, just because CT actually has somewhat of a high false negative rate. So this is like somewhat of a representative image of a scaphoid fracture. It's most common in the mid-third, and this can be managed non-operatively pretty well. There is a cast, a long arm cast or a Munster cast. Basically, the point is to reduce pronation supination to allow that to heal. You can do alternatives, but there's a high risk of non-union. And there's a pretty absolute rule that unstable or proximal pole fractures require ORIF. And once again, that has to do with the blood supply being retrograde. And just know that ORIF has a faster return to sport rate than non-operative treatment. Hook of the hamate is significantly less common, but does happen, and it's particularly common in sports that what I say have some kind of a stick. So like golf, baseball, racket sports. Once again, there as the blood supply has been studied. There is this kind of watershed area that you can see right on this picture, right in the middle, kind of towards the little bit at the base of the hook. And which is why you can get fractures there. This is going to be more of a direct force or the shearing force applied by the ulnar flexor tendons. So some people have looked at the sensitivity of each of these tests. Tenderness of palpation is pretty good. The hook of hamate pull test, this is performed by resisted DIP flexion, and this is because during flexion of the FDP and also the FDS tendons, this kind of creates a little bit of a lateral force against the, or I should actually say a medial force against the hook, which kind of reproduces the pain. So you'll want to get a carpal tunnel view. This is somewhat unique. This is how it's obtained to actually see the hook. This is a representative fracture. If you kind of look really closely, it's right at the base of the hook. This can be treated non-operatively, but actually the gold standard is excision, just because there is a high rate of non-union. Lunate fracture is actually very uncommon, and what you should think about instead, if this would present with ulnar-sided wrist pain, but think about Kienbach's disease, which is avascular necrosis of the lunate due to repetitive trauma. This also has the blood supply has also been studied for this. Just know that the one in the middle, type B, with just that linear blood supply, that has the highest risk of Kienbach's disease, just because it has the most poor blood supply to the entire lunate. Not really any specific tests can be done for this. This you will want to get an MRI. Once again, X-rays are probably going to be normal, but one thing you can look at is ulnar variance. I will go into more detail describing what ulnar variance is, but this is actually associated with negative ulnar variance because there's increased scapholunate stresses that can, with negative ulnar variance, that can increase the risk of Kienbach's. This is what a representative MRI would look like. It's that dark, hypoattenuation on the MRI. Early stage can be treated non-operatively, but ultimately it's likely to continue to progress. So a joint leveling procedure can be considered, which would have you'd shorten the radius so that it's at the same level as the ulna. But late stage is going to require an intercarpal arthrodesis or proximal row carpectomy. Just know that when you do remove that proximal carpal row, you are going to limit wrist motion, so that can affect return to play. Yeah. Pisiform fracture. Once again, not very common. No one's really, couldn't really find anything on blood supply to the pisiform, but this is going to be most likely due a direct force, kind of similar to the hook of the hamate. Type injuries, racket sports are really common. Once again, no really special tests. If you are suspicious of a pisiform fracture, you would get additional views, including this external rotation oblique and carpal tunnel views. CT is pretty good to visualize this. This is a representative image of that pisiform fracture right on top of the triquetrum right there. So first line actually for this one is non-operative treatment. It does heal pretty well. As we can see, return to sport in about 6 to 8 weeks. You can do a pisiformectomy, and this doesn't really affect wrist function. You can think of the pisiform really as a sesamoid bone within the FCU tendon. The FCU tendon attaches to the pisiform. So all it really does is increase the mechanical advantage of the FCU, but it's not really going to affect function. Here's what a CT would look like. Just it's that bottom bone with the fracture through that transverse fracture right through the middle. All right, so this is actually a pretty big topic that is actually kind of tough to condense. So scapholunate injury can lead to a lot of subsequent problems. So there is it's called the scapholunate interosseous ligament. It is a very important ligament that stabilizes and keeps the scaphoid and lunate in place together. This does occur once again. It's a type of Fuchs injury with direct impact after a fall that can cause the rupture. So incomplete is more common than complete. But if you do get a complete tear, something that can happen is called a dizzy deformity. And dizzy stands for dorsal intercalated segmental instability. I'm not going to spend too much time talking on this, and I encourage you to look this up because it's interesting, but it's a very detailed topic. Basically, what it means is that the scaphoid and the lunate they don't move in synchrony with any type of wrist motion. And over time, this leads to a slack wrist, which is scapholunate advanced collapse. Basically, that just means that it's advanced arthritis in the wrist. So the way this is tested is with a Watson test. You put a dorsally directed pressure over the scaphoid, and you move the wrist from ulnar to radial deviation. What happens is the scaphoid, because it's no longer connected to the lunate, is going to sublux dorsally. And when you let go of that pressure, it should actually fall back into place. And there's sometimes an audible clunk, or the patient will feel a clunk. So this X-ray shows something that you may find with a complete tear. It's going to be this scapholunate gap greater than 3 millimeters with a clenched fist view. You can also look at the lateral X-ray, which this is more so describing what the scapholunate angle is going to look like. It's basically the way this is obtained is by finding the vector, if you will, of the direction of the scaphoid and the lunate. The scaphoid is going to be this middle bone right here, and the lunate is going to be this kind of crescent-shaped bone at the bottom. And an angle greater than 60 degrees is going to be positive for a dizzy deformity, and you should suspect a scapholunate injury. MRI is kind of questionable, and wrist arthroscopy is going to be your gold standard. So here's how I've summarized kind of the treatment options for this. So for acute incomplete, you can do immobilization or arthroscopic evaluation with pinning. For an acute complete tear without carpal malalignment, you should repair that scapholunate interosseous ligament, just because it helps restore that normal range of motion of the wrist. Chronic injuries can be repaired late, but this is most likely will need to be treated with wrist arthrodesis. This is because you're going to start getting that slack wrist and that arthritis within the wrist. This does decrease range of motion, but it's been shown that this is actually pretty compatible with most sports. Salvage procedures here, proximal carpectomy, four-corner fusion. What this happens is you excise the scaphoid. I forget which bones are actually fused, but it's going to be the ulnar four bones are just fused together. Lunotriquetral injury is less common and doesn't have the same type of progression of injuries. So this doesn't lead to arthritis within the carpal bones the way that scapholunate ligament injury does. Once again, this also occurs during a type of Fuchs injury. The way it's diagnosed is by grabbing the lunate and the triquetrum with your hands, and these shear and shuck tests are basically you're translating the lunate and against the triquetrum. Either volarly or dorsally or kind of proximal to distal, and you're reproducing these shear forces that cause pain. So contrary to scapholunate injury, this lunotriquetral injury causes a Visi deformity, which once again can be obtained by looking at the lateral X-ray. Visi just means volar intercalated segmental instability. The scapholunate angle is going to be less than 30 for this. And once again, arthroscopy is going to be gold standard. And immobilization is actually a pretty good option for this. Otherwise, I listed these options here: debridement, arthrodesis, or shortening the ulna just to, like I said here, tightens the ulnar carpal ligament and stabilizes the lunotriquetral joint. Mid-carpal instability, this is not that common. I'm going to just quickly touch on this. Basically, this happens when you have attenuation of the ligaments that stabilize the proximal carpal row to the distal carpal row. Primarily, it's going to happen with this called this V ligament. So it is particularly the capito triquetral ligament that becomes attenuated. And basically, whenever you ulnarly or deviate your wrist, you're going to feel this clunk because the proximal and distal carpal rows are kind of rubbing up against each other, and they're not moving smoothly, which is why you'll hear that clunk. This can be treated non-operatively. Otherwise, you can reconstruct that ligament. So lunate and perilunate dislocation is rare, but it is often missed on initial presentation. I actually had a patient on the inpatient unit who was admitted for a stroke after a fall, and they did the x-rays, and then I looked back through the x-rays because the patient had persistent wrist pain, and we found an actual lunate dislocation. So once again, this is a type of Fuchs injury, and if you read here the mechanism of injury, it just depends on how the wrist is positioned and how you fall on that wrist, but it occurs in 4 stages. So first one here is you're going to have damage to the scapholunate ligament, then the lunotriquetral, the capitolunate ligament, then the lunotriquetral ligament, and then the radio ulnar ligament. And so that's this kind of circle kind of represents that sequence of injuries is required for the lunate to become dislocated. If it is a lunate dislocation and it dislocates volarly, you can get acute carpal tunnel syndrome, compressing the median nerve. What you'll want to do is look at lateral x-rays. So here is the difference between lunate and perilunate dislocations. In lunate, the lunate actually leaves its fossa within the radius and dislocates volarly. But a perilunate dislocation, the lunate stays in place and everything distal to it dislocates dorsally. So for an acute injury, Oh, here I just have representative images. This is a lunate dislocation, and this is a perilunate dislocation right here. Acute injury, if it's less than 8 weeks, just a kilos reduction, but ultimately is going to always need open repair. Chronic, you're going to get a lot of changes to the structure of the carpal bone. So you probably will have to remove the proximal row or do a wrist arthrodesis. Return to sport in about 38 weeks. Here talking about the distal radial ulnar joint and the TFCC. So the TFCC is the triangle fibular cartilage complex. Hopefully that tells you that this is a complex structure. There are about 3 separate structures within it. I think the most important thing to point out is that there's this articular disc that is avascular, which is kind of represented on the image at the bottom of the screen. And what happens is this TFCC helps provide it's a shock absorber essentially for axial loads against the wrist. And what's normal here is that the radius loads, it's about 80% of the force, axial force, and then the ulna takes about 20%. And this depends on the ulnar variance. So I have a table here that kind of describes how the ulnar variance changes and what load is expected, how it's expected to change. And so finally, this is a good opportunity for me to actually talk about ulnar variance. So this is just going to be the height of the ulna relative to the height of the radius. And this is how it's measured. The middle picture here is what normal variance looks like. The picture to the left, the X-ray to the left, is a positive ulnar variance. And the right is a negative ulnar variance. And the ulnar variance can also change naturally with position of the wrist. So it's more positive with pronation and grip, and then therefore more negative with supination. So TFC injury, axial loading with a rotational stress. These are the common sports that you can see it in. It can be traumatic or degenerative. As I mentioned, that ulnar variance is increases with pronation. So you're going to get pain with pronation because it's going to be compressing that TFCC. The fovea sign, this can be sometimes called the ulnar-sided snuff box. And it's basically the space that is just distal to the ulnar styloid, and it's in between the FCU and the ECU tendons. That's the pressure point, and you'll feel pain there. Ulnar carpal stress test. This is just stressing, passively deviating a patient's wrist to ulnarly, and that's going to reproduce that pain. So X-ray is always going to be normal because it's a cartilage injury. MRI is actually false negative rate. So, oh, here I have a picture. Yeah, that's the fovea, the spot of the fovea sign. MRI, high false negative rate. This is what it may look like. You're going to have that increased signal on T2 imaging with the increased fluid, but arthroscopy is going to be your gold standard. So this is how I kind of broke up the treatment paradigm. If it's a traumatic central tear, you should do debridement followed by splinting. If it's a peripheral tear, you can repair this. Once again, this goes back to the blood supply, but you're still going to need some type of immobilization. And then for a degenerative tear, you're going to want to shorten that ulna because it's just going to be abutting that TFCC and just reproducing that pain constantly. Okay, so that is my the first part of the article. I'll take any questions or comments.
I'd really like to thank you, Nate, for going through that, and you stayed on time. You did a good job really teaching it. Those pictures that you put up really helped. And for our learners on this call, our residents, fellows, and students, I think you should bookmark this article as something like if you're going out this weekend to cover games. If you have a hand injury, it's probably in here and it'll help you to, at least broaden what you're looking at there. I really like what you're talking about. I know it's to be continued, but good job so far.
Dr. Shabbir, do you want me to, I'm going to just jump right into the second one, the second article.
I'll just do a brief introduction and then.
Sure.
So thank you so much for your presentation. So the question, if you guys have any questions throughout the second presentation as well, you can send it into the chat box and we'll address them at the end as well. So now Dr. Michalak will share his second presentation on the article, Injuries of the Wrist and Hand, Part 2, Overuse Injuries of the Wrist and Traumatic Injuries to the Hand. Dr. Young has served as club mentor for this article as well.
All right, so yeah, overuse injuries of the wrist and traumatic injuries of the hand. Same learning objectives. So overuse injuries are incredibly common, usually just due to repetitive microtrauma. Let's get into it. Okay, Deck-Core veins. Very common. This is inflammation of the first extensor compartment. The first extensor compartment of the wrist is going to have your tendons, your abductor pollicis longus and your extensor pollicis brevis. It's just that repeated radial ulnar deviation, flexion extension of the wrist that causes inflammation within that tendon sheath. Hopefully, everyone's familiar with the Finkelstein test. This is when you put the thumb inside the palm and then passively ulnarly deviate a patient's wrist. It should reproduce pain right over that first extensor compartment. This is treated very well non-operatively. You can do steroid injections. It's almost never going to need surgical release and just gradually return to sport so that you're strengthening that tendon or those tendons. Intersection is kind of on your differential diagnosis for Deck-Core veins. This is actually going to be a shearing force of the first extensor compartment crossing over the second. So your second extensor compartment is going to have your extensor carpi radialis longus and brevis. The tenderness point is going to be more proximal than the tenderness point of the Deck-Core veins. So about 5 centimeters proximal to the radiocarpal joint is where a patient will point to. Once again, this can be treated non-operatively, gradual return to sport. ECU tendonitis can be common, especially in tennis players, just with that two-handed backhand. This is going to be treated non-operatively, it's never going to need surgery. However, ECU subluxation is a little bit of a different beast. This is going to be attenuation of the ECU subsheath. So this is what a normal subsheath is look like. It's going to be nice and tight. It's not going to allow the ECU to sublux. But what can happen with subluxation, two things. Well, attenuation, it's kind of just going to move in and out of that groove right there. And then you can also get rupture of that sheath. This is actually becomes problematic where you can see on the bottom row, if the more, I guess it's going to be more dorsal side of the sheath ruptures, the ECU can actually sublux out completely, and then the other piece of sheath is going to be stuck within and prevent proper healing. So this is actually more likely going to need operative repair or subsheath reconstruction. So the reason why this happens is, or what you're going to see is ECU subluxation with supination. So the ECU tendon is on the very, very lateral side of the ulnar side of the wrist. And in pronation, there's no tension on it. But in supination, as you can see in this picture here, there's this little bit of angulation that happens because it moves a little bit more dorsal. And that causes that angle and that stress that kind of just pulls it out of the out of that subsheath. So this can be well seen with ultrasound, and acute injury can be casted. But once again, depending on the type of injury, especially like the location, it might more likely need reconstruction. This is kind of a broad term, wrist flexor tenosynovitis, similar mechanism action to like our mechanism injury to Deck-Core veins. It's going to be repeated wrist flexion. FCR tendonitis is very rare. You're just going to either do resisted flexion, or you can also do a diagnostic injection for the FCR just to see if it relieves the pain. One thing that I do want to emphasize that the FCR is not in the carpal tunnel. It enters the hand or wrist through a different tunnel outside of that, so it's not affected in carpal tunnel syndrome. FCU tendonitis is more common. This can be treated non-operatively as well. And once again, you can kind of do a pisiformectomy, as I kind of mentioned before, with this lengthening procedure, but that's often not necessary. Okay, this is what a FCR tendonitis might look like. You're going to see that fluid around the black is the tendon, the white is the fluid surrounding that tendon in that subsheath. Dorsal impingement syndromes. I'm going to touch just really briefly on this. It's just a broad term for pain that occurs with repetitive dorsiflexion. Gymnasts are going to be at your highest risk because they're doing so much axial loading, especially if their routine is exceeding 35 hours per week. So dorsal radius epiphysitis, I just want to comment on that. It's just going to be separation of the physis in skeletal immature athletes. And it occurs in different stages. This is a representative X-ray. This is what an MRI would look like. I'm going to just skip over scaphoid fracture and refer you to the article for that stress fracture. Dorsal capsulitis, once again, this is just kind of a diagnosis of exclusion. You kind of ruled out some other stuff, but you still having some chronic dorsal wrist pain. An occult ganglion can occur. This is what it might look like on an MRI. This is a ultrasound image of what you might see, just this hypoechoic fluid structure. This can be treated with ganglion excision. And then, so the reason why you do a PIN excision is because the PIN provides sensation to the dorsal wrist capsule. So if you just excise that nerve, you can't feel pain in your dorsal wrist. So now we're going to move on to traumatic injuries of the hand and, traumatic injuries of the fingers. This is a extremely broad topic. You could probably spend a whole hour on this alone, but I'm just going to do general trends that I found. So there are common fracture patterns. The distal phalanx is usually a crush injury. That's going to be your left image, your left X-ray here. Mid phalanx often has a transverse type fracture, and a proximal phalanx is usually you can see a spiral fracture just due to the different tendons that insert and cause deviation forces on that bone. The injuries are going to be low energy, so oftentimes are stable and therefore can be casted or splinted. Often like buddy taping can be sufficient. But for anything that has malrotation or scissoring, this requires a CRPP or ORIF. This is actually a little bit new, maybe a few years. You can actually do intramedullary screws right now, which have good results. They're very small screws. They don't have the bulkiness of any type of plate that might be needed, so they're not going to be causing any friction on your flexor extensor tendons. And that seems to work pretty well. This is what scissoring might look like when you ask a patient to make a fist. You're going to see that the fingers are overlapping. One thing I do want to point out, though, actually, that the fifth digit does have some normal scissoring. If you were to just flex it on its own, you're going to see that it overlaps with your ring finger anyways. That is normal, and that just has to do with the orientation of the fifth metacarpal. PFP joint injuries, broad category. This includes dislocations, fractures, injuries to ligaments or around that joint. Mostly these can be treated with non-operatively with just immobilization. Once again, likely a low energy injury and has a pretty quick return to sport or longer if there's persistent laxity. So I'll talk about a few of them. Joint dislocation, the dorsal is most common. Anyone who plays any sports with the ball is usually how it happens. You can just do stressing, either volar, dorsal, lateral stresses. And the Elson test is something that I'm going to talk about a little bit later when I talk about a different pathology that can happen. So this is the mechanism of action, injury for dorsal. For dorsal dislocation, once again, non-operative treatment, pretty quick return to sport. Volar is going to have a little bit longer return to sport and may actually require operative repair just because you get entrapment of the lateral band. Oh, let me go back. I didn't realize, I forgot I had a few pictures. So this is dorsal dislocation, volar dislocation, lateral dislocation. And this is what might happen when you have a it's the lateral band or it's connected to the lumbrical, it can kind of get entrapped within the joint space. It's going to require open repair. PIP joint fracture, you're going to have similar should be mechanism of injury, sorry. Proximal phalanx fractures have this pretty common fracture patterns. This is kind of what it would look like. These middle phalanx fractures, this is going to be specifically of the base of the middle phalanx. You can have either a volar fracture, a dorsal fracture, or a pilon fracture. And pilon is just going to be just direct longitudinal axial force that kind of causes a more comminuted fracture pattern of the base of the phalanx. This is what a stable injury is considered. So extra-articular fracture with less than 10 degrees of angulation, less than 2 millimeters of shortening, and no rotational deformity. These can be non-operatively treated with, once again, it's that classic 3 to 4 week return to sport. But if any of those things are, if it's unstable, which is the opposite of what I just mentioned, that's going to require surgery with a little bit longer return to play. So thumb, a little bit more special of a finger. You can get dislocations, but these are actually quite rare. If that happens, there's going to be this volar beak. So that's just right here, this anterior volar beak ligament. It's going to be ruptured in order to actually dislocate it. There are 2 named fractures of the. Oh, this is just a representation of how you might fix it operatively. You reconstruct the volar ligament you split the FCR tendon, you kind of wrap it around the thumb and through the thumb to kind of help stabilize it. But the 2 named fractures of the thumb, of the base of the thumb, are Bennett and Rolando. So, and this occurs during an axial load on a flexed thumb. The Bennett is going to be a 2-part fracture, and then a Rolando is going to be a 3-part fracture, and it happens this kind of Y or T-shaped pattern. These can be reduced and put in a thumb spica if it's not displaced, but otherwise it will need some kind of operative repair. And non-throwers can return to sport more quickly. I think that makes sense just because you're less likely to re-injure. But throwers are just because if you're catching and throwing, you might re-injure that operative repair. So these are some X-ray images. The one on the left, that's what a Bennett fracture would look like, and the one on the right is a Rolando fracture. Oh, sorry, no, these are both Bennett, and this is a Rolando fracture. Okay. MP injuries, once again, all kind of similar mechanism of injuries. This can be immobilized with a pretty quick return to play, but if it's not reducible, it's probably because it's the thumb, the metacarpal, the first metacarpal has kind of entered in between the FPB or the flexor pollicis brevis, and this is going to require open reduction. I think this skier's gamekeeper's thumb, it's a little bit more common of an injury. It's gonna, like you see in this picture, there's a radially abducted thumb and you fall on top of it. It's gonna cause the stress that injures the ulnar collateral ligament of the thumb. Something that is important to be aware of is something that's called a Stenner's lesion. And this is when the adductor aponeurosis falls in between the 2 parts of the ruptured ligament. And this ligament will not heal. It's going to require surgical repair to fix it. This can be seen on X-ray with stress views. You just provide flexion or extension stresses, and that opens up that joint space. It can be seen, if you're concerned for a Stenner lesion, you should get an MRI. This is what it might look like. Ultrasound can also be used to identify. Once again, so partial tear can be immobilized with good results. If it's less than 8 weeks post-injury and it's a complete tear, you should do primary repair. But if it's greater than 8 weeks, you'll have to probably use some kind of tendon graft to reconstruct. So the next two pathologies are actually quite common. So mallet finger, this is what's called the Doyle's classification. It's going to be rapid flexion force to the DIP joint, and causes injury to the extensor tendon or the extensor mechanism. The long finger is going to be the most commonly injured, just because it's the longest and most exposed. When you look at the finger, it's going to be resting in slight flexion, and you won't be able to actively extend that DIP joint. You should always get an X-ray to rule out a fracture. As you can see, that fractures can happen in these representative figures. And this can be treated entirely non-operatively with excellent results, and can even be treated 3 months non-operatively after injury. And these are some examples of some splints that you might place. You just immobilize the DIP joint, not the PIP, and should heal in about 6 to 8 weeks. But the patient can never take it off. So you have to teach them how to clean and wash their hands. They have to keep it on 24/7. Jersey finger is the opposite. This is when you rupture the flexor tendon. The ring finger is actually more common because during grip, it's actually more prominent than the other digits. There are 3 types. Type 1 is when the FDP tendon retracts all the way to the palm. Type 2 is when it retracts to the PIP joint. And type 3, there's a bony injury, which actually kind of helps you because it prevents retraction, because that bone doesn't slide through the pulleys and the flexor side of the finger. Kind of opposite, you'll see the finger that's rested in slight extension and no active PIP flexion. Once again, get an X-ray to rule out avulsion. This actually has to be treated operatively. You'll have very poor results. The finger won't heal, especially in type 1. You have to operate pretty quickly because the FDP tendon will get retracted and scarred down and get stuck within the palm, and you won't you won't be able to extend it out into the finger. So this should be treated pretty quickly. Types 2 and 3 can be delayed, but you'll have suboptimal results. So basically, you want to treat as quickly as possible for any of these. So boutonniere injuries, it's kind of similar to a mallet finger, except you have injury of the extensor tendon over the PIP joint instead of the DIP joint. And I only recently learned this, of why it's called a boutonniere deformity. It's because a boutonniere, it means button. So it's a buttonhole deformity where something comes in up through, in this case, the PIP joint comes up through the extensor mechanism, or at the level of the PIP. And so this is what you're gonna see on a patient with this deformity. You're gonna have PIP flexion and DIP extension, because when the extensor mechanism ruptures, you're going to change the forces on those joints, and the lumbricals are actually going to turn into DIP extensors instead of flexors as they normally are. So here is the Elson test. What you have the patient do is rest their finger at the edge of a table and let it hang off. And you're going to ask them to extend their finger, and you're going to provide resistance at the level of the PIP. In a normal finger, and you can kind of test it on yourself, the DIP is actually supple. But if you have a boutonniere deformity, you're actually going to have that DIP held in extension. So acute injuries can be treated non-operatively. Once again, you'd wear a splint, and the splints are very similar to what you would do for a mallet finger, and you just need to put it over the PIP joint and leave the DIP joint free. But chronic injuries, you're going to have a little bit more scarring, so you can do some serial casting or splinting, but probably going to need surgical repair for that. So boxer's knuckle, this is going to be rupture mostly to the sagittal band of the extensor mechanism. So the sagittal bands, there's 2 of them, and basically they help keep the finger extensors or the extensor digitorum, that tendon, it keeps it in the middle of your hand. So if you're going to see that if you flex your fingers and you look at your MCP joints, you're going to see that the extensor digitorum tendon, it stays right in the middle of the MCP. And that's due to the sagittal bands. So repetitive punching damages those sagittal bands. It makes the extensor digitorum tendon sublux either laterally or medially, and it's going to be quite painful. So the way this is treated with MP extension for 6 weeks. Otherwise, you can repair it operatively. And this is kind of just how you would do that repair. And it's actually going to take a long time to heal, about 5 months. So that's a long time to be out of your sport. This is kind of what it looks like on a figure, and also what it would look like on a patient. And a little bit longer than the other one, but that's it.
Thank you so much, Dr. Michalak, for your presentation. Before moderating the Q&A, I'd like to give his club mentor, Dr. Young, an opportunity to add any additional comments about the article or topic.
Dr. Michalak, when you and I prepared for this, we were saying, "Oh, there's so much things. You did a good job," and I really love your anecdotal stories there. It was really fun. I hope I speak for the whole group that I feel like I went through a whole elective, or at least a sports medicine orthopedic hand topic in like 40 minutes. And so as we go through this, I can imagine most of you will be covering sporting events this weekend. Look through the article. I mean, you're probably going to find something. That's how high yield it is. So as you folks prepare for upcoming exams, I think this is rich with many different topics to study. So good job. It was wonderful.
Thanks, Dr. Young.
I had a couple of questions.
Please go ahead.
Hey, this is Dr. Foxer. Good presentation. Everything you said is on the board exam. Some additional stuff on wrists. They do love the extensor compartment of the wrist, and there's 6 compartments. And the new term in learning for the board exam is called overlearning. And so you really just need to memorize all the different structures in the 6 compartments. And there is a distal intersection syndrome. You mentioned proximal intersection syndrome on the last test. So everybody needs to look up distal intersection syndrome and learn about that.
Thank you. Any other questions regarding the 2 articles? Otherwise, we'll proceed forward. I am pleased to introduce our 3rd presenter tonight, Dr. Kevin R. De Jesus, and his club mentor, Dr. Aurelia Nattiv, who is also one of the primary authors for the article that Dr. De Jesus is presenting. Dr. Kevin De Jesus is a 3rd-year PM&R resident in the PM&R and Sports Medicine Residency Program at the University of Puerto Rico. He completed a 2-year PM&R research fellowship in the same program and is currently involved in multiple research projects. His research profile includes contributions to musculoskeletal evaluation, tendinopathy, shoulder evaluation, and return to sports. Specifically, he's interested in injuries in baseball athletes, looking at ways to use regenerative medicine to manage acute injuries. Dr. De Jesus is also interested in applying sports medicine concepts to performing arts medicine, especially implementing treatment strategies for musicians, which stems from a personal background as a professional bassist. He is currently leading an injury database development for those performers in collaboration with the Performing Arts Medicine Society. He is finishing a team as part of the Resident Council Board of the American Academy of Physical Medicine and Rehabilitation. His presentation is on the article, The Male Athlete Triad, a consensus statement from the Female and Male Athlete Triad Coalition, Part 1, Definition and Scientific Basis. I'll also like to thank Dr. Aurelia Nattiv for serving as his club mentor and as one of the primary authors of the article being presented. We will look forward to hearing your insights about the article and topic after Dr. De Jesus shares his presentation. Dr. Nattiv is a professor in the UCLA Division of Sports Medicine and Non-Operative Orthopedics, Department of Family Medicine and Orthopedic Surgery. She has served as the director of the UCLA Metabolic Bone and Osteoporosis Center for over 20 years. and currently the UCLA Bone Health Practice. Dr. Nattiv is an associate team physician for UCLA Athletics and has been involved as a team physician and consultant with several national governing bodies, including USA Gymnastics and USA Track and Field, as well as a USOC. She is a past president of the Female and Male Athletic Triad Coalition and has served on the board of directors for AMSSM 2 terms and ACSM, and is a fellow of both AMSSM and ACSM. Dr. Nattiv's research and publications are in the areas of prevention and management of bone stress, injuries, bone health osteoporosis, and the female and male athletic triad. Most recently, she is the lead PI on the Department of Defense grant assessing the safety and efficacy of extracorporeal shockwave therapy in the management of high-grade bone stress injuries. Now I'll turn it over to Dr. De Jesus.
Thank you, Dr. Shabbir. I'm very grateful for this opportunity to be presenting in tonight's learning club. And I wanted to shout out to Dr. Nattiv for her support and putting together these slides. And I think it's a great opportunity for us to have the primary author and some of the other authors here tonight from this consensus statement. So let's jump right in. We're going to be talking today about the male athlete triad. And I wanted to give you a little bit of background of how this concept has emerged. As we have increased our understanding of the female athlete triad, we know a little bit more about the prevalence, about the conditions that this triad includes. And we have seen some observations about the male, similar presentations in the male athletes and male participants. And we see how a low energy availability plays a clear role in modulating reproductive function and skeletal health. We know that there's a broader and more comprehensive concept called the REDS, or the relative energy deficiency sports. And this is based on the female athlete triad. So there was the female athlete triad international consortium got together in 2017. So the available evidence for presenting male athlete triad that was similar to the female athlete triad. And that's what they got together in the two-part consensus statement. And we're going to be presenting today the first part of this consensus statement that focuses on the definition of the basic concepts of the male athlete triad. So the definition of the male athlete triad is a syndrome of 3 interrelated conditions. The first one being energy deficiency. The athlete uses more calories of the calories that is consuming, meaning that there's an energy deficiency that refers to a state where the energy intake is insufficient to meet the energy demands regarding to exercise and normal physiological processes. This condition leads to other compensatory metabolic adaptations that we're going to be talking about in a couple of slides later. This energy deficiency causes a suppression of the reproductive and the hypothalamic pituitary gonadal axis, producing reproductive hormones, testosterone, as well as having an effect on spermatogenesis. Both the energy deficiency and the suppression of the HPG axis is going to impair bone health, which puts the athletes at risk of stress fractures and shin splints. We can see that these outcomes occur along a continuum from a subclinical state to more severe clinical conditions. At the optimal side of the spectrum, we can see the influence of optimal energetic status on a normal HPG axis and an optimal bone health. And we can see as well that a normal HPG axis has an impact in bone health as well. We can see the gray lines that run bidirectionally. That means that through the continuum of severity, there's a reversibility of the condition, such that an individual can improve or worsen over time, specifically for the energetic status and the HPG axis. However, we can see a dashed line and a question mark in bone health because there's no enough evidence to see that there's fully reversible effect of bone health through trying more research on that. So let's discuss the first part of the triad, which is energy deficiency and the low energy availability in male athletes. So we're going to be discussing several evidence statements from these conditions. And the first one being, what is the evidence for chronic energy deficiency availability in male athletes? Energy availability is defined as the energy that is available for bodily processes minus the energy expenditure in exercise training. However, although this seems pretty easy, it's actually has several challenges when you're actually measuring that, because the calculation of energy availability does not consider non-purposeful energy expenditure, meaning activities that are not associated with training or exercise, which can vary greatly from athlete to athlete. Also, it can be quite challenging in athletes that are free living athletes, which means that they're not in a supervised environment like independent or non-professional athletes. Low energy availability is an inadequate energy intake to support the total energy expenditure, causing a state of energy deficiency, and promoting metabolic adaptations to compensate for that deficiency. Those adaptations being suppression of the resting metabolic rate, loss of weight, low BMI, and suppression of metabolic hormones like D3 and leptin, which are important for appetite regulation, energy expenditure, body weight regulation. There's evidence on the prevalence of low energy availability in males, in some sports comparable to the female counterpart, and in some sports even higher than female athletes. Contributing to that energy deficits, we can have athletes that have a low energy intake, and that has been evidenced in several studies, specifically in runners and cyclists, when we see that there's an increased expenditure in comparison with the intake of energy that they're having. And this can range, for example, in the study for 600 calories per day, in cyclists 1,300 calories per day, and it can be even higher than 2,000 calories per day in 24 hours, as we can see in ultra-endurance cyclists. Although there's some studies that show that energy deficiency can affect metabolic hormones in men, it is not quite defined how low it needs to be. Some studies show that low energy availability may not cause a reduction in some of the hormones, but they do cause a reduction in leptin and insulin. And in more severe energy deficits, we can see a dramatic reductions, for example, in insulin growth factor 1, which promotes cell growth, muscle growth, and bone health. So what we can conclude for this part is that severe energy deficits is associated with alterations in metabolic hormones, and that the energy deficits needed to induce metabolic hormone perturbations in men seems to be more severe than those in women, and that we need to establish a better idea of what is a low energy availability in men. So which pathways contribute to this energy deficiency? We can see that there are behaviors contributing to the inability to meet energy needs that are similar to the female athlete, including intentional weight loss, inabundant undereating, disordered eating, and clinical eating disorders. However, the tools that are available to measure disordered eating are not as accurate in men, because we tend to score lower on this test. And male athletes have different body ideals. They want bigger muscles, right? This desire can lead to different manifestations of disordered eating behaviors compared to women. There are actually studies about disordered eating in male athletes that propose that there's an 8% of risk or meet criteria for eating disorders in male athletes, and even higher in some sports like anti-gravitation sports, about 22%, and weight class sports at 18%. Some other sports that are high risk for disordered eating are cycling, weight class sports, and lean sports like dancing, jumping, cycling, swimming, and gymnastics. So evidence for this part is that there's an increased risk for developing disordered eating or eating disorders. However, the eating behaviors and underlying motivations may differ from those observed in exercising. So let's go to the second set of conditions, which is the implication of exercise in hormones. Specifically in the HPG axis, we can see how exercise can have an effect at all levels of the APG axis. Starting at the hypothalamus level, there can be a decreased gonadotropin responsiveness to a gonadotropin releasing hormone. There are studies that report a decrease in sexual desire with an increase in exercise activity or high intensity exercise. There is a decrease or a suppression of testosterone and luteinizing hormone, a level of the pituitary and endocrine levels, and there can be an effect on spermatogenesis as well. So talking about specific reproductive hormones and how they're suppressing the male athletes, we can see testosterone concentrations in exercising men in several studies, and measuring the testosterone levels before exercise and after exercise, we can see that testosterone decreases, and this has been consistent in several studies. As well, we have some evidence from runners. Runners with high intensity training have a lower total testosterone levels and lower LH pools, as well as in other studies, and a decreased responsiveness to gonadotropin releasing hormone. And we can see that runners with lower training loads, there's no changes in LH pulse frequency. However, some studies still report that there's suppression of LH and T testosterone. Some randomized control trials can help us understand this a little bit better. There's one that put athletes on a moderate intensity exercise regimen and high intensity over 60 weeks. And they saw that the high intensity group had a decrease in testosterone concentration, LA and FSH in comparison with the other group. And we can see that other studies with lower deficits show no significant reductions in testosterone levels, although the energy availability level is very low. So in conclusion, high volume exercise training and acute prolonged exercise can cause a reduction in testosterone and hormone levels. So what is the effect of exercise on spermatogenesis? There are evidence and studies in triathletes and high mileage runners with high intensity training per week that shows that there's a lower sperm concentration, a total sperm number, in comparison with recreational athletes or less competitive active athletes. As well, there's decreased mobility of sperm, increased number of immature sperm, and decreased sperm penetration in the cervical mucus, which contributes to infertility. There are longitudinal studies. There's an interesting study that put men in two groups, one non-exercising control group and an exercising group. And the exercise group show a reduced ejaculate volume, sperm concentration, and sperm number. And in a long-term trial over 60 weeks, in the comparison with the high intensity group and the moderate group, there was an increased reduction in sperm density, motility, and morphology. And in the mother group, only the sperm concentration and motility was affected. However, they saw an increase in testosterone from the normal range to the subclinical gray zone. So what is the effect of exercise in sex desire? There are some surveys that have been done in recreational and competitive athletes, comparing the training intensity and duration with their association with libido. Men with lower training intensities may have a high or normal libido, and athletes with an endurance trained athletes can have a decreased libido or a decreased sexual desire. So there's evidence that just suggests that endurance trained male athletes may experience decreased libido, particularly those with that low energy availability and reduced testosterone concentration. So there's a correlation between training intensity and sexual desire. So what happens when we recover the patterns of reproductive hormones with an increased energy intake? There are several studies that look into that. Athletes were exposed to high training loads, and they saw a suppressed concentration of reproductive hormones, specifically testosterone. And after a period of recovery, they saw a recovery of the levels of those hormones to pre-exposure values, return to baseline, and even a faster recovery in moderate volume concentrations on versus a high volume training group. However, some studies show that some of these athletes may remain with a low level of testosterone after this recovery, although this was a fairly low recovery time. So there's level A evidence that there's a recovery reproductive hormone once you remove the stressor of exercise, or once time has passed from an intense exercise period. And we have a recovery in spermatogenesis with an increased energy availability. In the 2-week trial, where they put the two groups into an non-exercise group and an exercise group, there was a resource or recovery to pre-training values within 72 hours in the exercise group. For values of ejaculate volume, sperm concentration, and sperm number. In the long-term trial, they needed a longer recovery period. So that there is a correlation between the amount of training or exercise load and the time needed to recover their spermatogenesis and their values before exercise. So as a conclusion for this part, there's recovered spermatogenesis in men that occurs promptly once the exercise is removed. So in the last part of the triad, we're going to discuss bone health. So what evidence for poor bone health in male athletes is affected by the triad? We can see that risk factor for a low bone mineral density in male athletes include energy deficiency, a low body weight, hypogonadism, and high training loads. And some sports that are more at risk for low bone mineral density include running, cycling, swimming, specifically distance running, low impact, and non-impact sports, which are at a higher risk of low bone mineral density and stress injuries. So there are a number of studies that look into that, and they show how impaired bone health and a higher risk for stress injuries are engaged in sports that emphasize leanness. Specifically, what kind of sports they have looked into. They have looked at runners. Elite runners and adolescent runners have lower spine and head bone mineral density. And when you compare moderate C scores lower than 1, when you compare it to non-runners, this is relatively higher. And even with severe C scores, about a 4% range, you can compare it with 0% in non-runners because they don't get to those severe levels. In elite runners, they can go as high as 40%, presenting with a C score of severe level below 2, and as well as elite distant runners. There's some other evidence in low impact or non-impact sports like cycling and jockeys, where they also can see a reduction in low bone mineral density at 32% and 29%. So in conclusion in this part, there's a prevalence of low bone mineral density that is significantly higher in men participating in linear sports, and low impact and non-impact loading sports compared to those in non-linear sports. So what is the impact of training load and cross training on bone at specific sites? So we're going to look at bone mineral densities at the level of the spine and the femur. At the level of the spine, this is not associated with the training load or biomechanical variabilities, but it is influenced by the metabolic and energy factors such as hypogonadism or low energy availability. So this suggests that the spine is more susceptible to energy and hormonal imbalances than to a mechanical loading. However, at the femur, this is more strongly linked to training load and mechanical loading patterns experienced through the activity. So what we can see is that high impact loading may help mitigate some of the risks of energy restriction. So in male athletes, hypogonadism and energy deficiency has a strong influence on the lumbar spine, while training load has a stronger influence on the femur bone mineral density. High impact is important as it can reduce the negative effects of energy restriction on bone. So talking about the relationship with bone health to energy status, there's correlation between a low bone mineral density to low energy availability state, and this has been shown with cyclists and runners, who they see when they have an energy deficiency state, they have a lower bone mineral density scores, as well as cyclers that have long seasons and they have a competitive seasons, for example, of 9 months. They have a significantly reduced bone mineral density at the level of the hip, at the femur. Smaller seasons, like in the summer, some studies show that there's no change. So there's a correlation between the time and the intensity of the training and bone mineral density. As well, when they compare power athletes to endurance athletes, there's a greater increase in lumbar spine bone mineral density in power athletes compared to endurance athletes, which indicates the importance of weight-bearing exercise to have a positive effect on bone health. So these studies provide the evidence that there's a relationship between energy deficiency and low bone mineral density. However, more studies are needed to confirm these effects. So how is strength, geometry, and the structure affected by exercise? There's some evidence from female athletes that they have decreased trabecular density and number. There's an increased trabecular spacing. Remember that trabecular bone is one with porosity, so the porosity in this bone is increasing, predisposing it to stress injuries. And as well, the cortical part of the bone is thinner. So participation in high impact and bone loaded sports improve the bone geometry and trabecular bone and has a higher failure load compared to non-impact sports such as swimming. Athletes that have a history of stress injury at trabecular ridge sites, like pelvis, the femoral neck, and the calcaneus, have an increased risk of having low bone mineral density. These athletes that have bone stress injuries at trabecular sites have a prolonged time to return to sport compared to those with stress injuries at cortical sites. So what we can conclude for this part is that stress injuries at trabecular sites are at increased risk for low bone mineral density compared to those with stress injuries at cortical risk sites. So what about the risk for bone stress injury and stress fracture in male athletes? There are studies in male runners that show that there's a high prevalence for stress injuries in adolescent runners, and that male runners with a history of previous fractures and repetitive competing season have an increased risk of stress fractures as well. So there's a cumulative effect and with the risk factors from the male athlete triad that lead to a higher prognosis for poor bone health. There's some studies in the military personnel that show the similar things, that those with the stress fracture had significantly lower spine, hip, and total bone mineral density compared with those without stress fractures. As well, some recruits have stress fractures with compromising bone geometry and have a smaller trabecular cortical side, lower tibial segments, and a smaller femoral neck diameter. So a history of previous stress injuries is associated with an increased risk of future bone stress injuries. It's irreversible, so there's no evidence for available that supports the reversibility of low bone mineral density or improved bone geometry in response to refeeding in male athletes or exercising men. So we haven't seen that refeeding or increasing that energy availability has reversibility after there's effects already in the bone health. And lastly, what is the relationship of energy deficiency to bone marker metabolism? There's evidence that with energy deficiency, there are a decreased volume in bone formation markers, and there's an increase in bone resorption markers. And some studies with energy restriction combined with training in the treadmill, they can see a reduction in bone formation markers, however, no significant change in bone resorption markers. However, some studies have contrasting findings, as well as showing a reduction in bone formation markers and increase in bone resorption. So there's evidence level C that the effect of energy deficiency on bone turnover markers in athletes and the result are inconsistent. So to summarize the key findings of this consensus statement, in energy deficiency, energy deficiencies is present in a subset of male athletes, particularly those in linear sports, and the magnitude and the duration of the energy deficiency required to induce metabolic hormone alteration is likely more severe than in females. The pathways to low energy availability are similar between male and females, but the psychological factors may be different. About the reproductive function, exercise is associated with reproductive suppression. Reproductive hormone concentrations are suppressed, semen quality is impaired, and sexual desire decreases due to exercise. And there are reproductive impairments, recovery after the removal of the stressor. Bone health, male athletes in linear sports have impaired bone health, are at higher risk of bone stress injuries, but more research is needed to understand bone turnover markers and bone microarchitecture. With that, I finish.
Thank you, Dr. De Jesus, for your presentation. Before moderating the Q&A, I'd like to give his club mentor, Dr. Nattiv, an opportunity to share additional comments about the article or topic.
Sorry, that was an excellent presentation, Dr. De Jesus. That was really very comprehensive and captured all the highlights, so great job. I did want to mention that this again is the first of a two-part consensus statement from the Female and Male Athlete Triad Coalition. We had convened a panel of experts in conjunction with an ACSM meeting, and the result from the Female and Male Athlete Triad Coalition were these two papers. This is the first of two parts, and I also want to just mention that two of the authors are here. Michael Fredrickson, who's the current president of the Female and Male Athlete Triad Coalition, and Liz Joy, former president of the Female and Male Athlete Triad Coalition and of ACSM. And so if they have comments as well, but we did want to leave questions for the most important part is the Q&A. So again, that was a great job. And if we have time for questions for Dr. De Jesus, and he has backup here too, just in case, questions from the audience would be great. I see one from Dr. Troxler. Hi, Mark.
So for your athletes with a low testosterone level, would it be a doping violation to give them weekly testosterone injections to normalize their testosterone level?
Dr. De Jesus, this is actually applies a little bit more to the second paper, which talks about diagnosis and treatment, but did you cover that at all in your review, Dr. De Jesus?
I think it's very specific about the doping violation rules and Wardha. So I don't know how that covers specifically with those athletes that have already increased testosterone levels.
Okay, this isn't as much a part of this paper, but for the second part, when we talk about diagnosis and treatment, similar to the female athlete triad, the treatment is correcting the energy deficiency. And so it wouldn't be treating them with the testosterone, it would be looking at the source and correcting the source, looking at all the risk factors and correcting the energy deficiency, which is the initial contributing cause. So by better fueling and education, increasing their energy stores, and by rest treatment of the underlying problem, it's reversible in most cases. That over time, if they are in the group, so not everyone gets the low testosterone, but if they are in the group that does have the decreased hormonal, the hypogonadism, and the related effects, then it is usually reversible with increasing their energy availability, increasing the energy stores, and improving fueling. So they typically we don't give testosterone in these cases for adolescent and young adult male athletes with the male athlete triad.
Thank you. Our second question is, would a therapeutic use exemption, TUE, be accepted or rejected?
I think that's related to the first question. We wouldn't be doing a TUE in this case. And if Dr. Fredrickson or Joy want to comment further, feel free to do so. But so again, it would be correcting the underlying problem, and the testosterone would, it does typically increase And we have seen this a fair amount, especially in distance runners. So this is a very common entity in the distance running population, as in other endurance athletes. And we mentioned before the weight class athletes.
Thank you. Any other questions or? Okay, I'd like to thank our presenters, Dr. Nathan Michalak and Dr. Kevin De Jesus, for their outstanding presentations. Learned quite a lot today. And I'll also like to thank tonight's club mentors, Dr. Justin Mark Young for serving as a club mentor for Dr. Nathan Michalak. And I'd also like to thank Dr. Aurelia Nattiv for serving as a club mentor for Dr. Kevin De Jesus. I'll also like to thank everyone attending tonight's AMSSM Journal Club meeting. It was my absolute pleasure to serve as the club advisor moderating tonight's Journal Club meeting. I'm also pleased to announce our next AMSSM Journal Club meeting that will be held on Monday, November 4th. That's my birthday as well, at 8:30 p.m. I hope you will make plans to join us. I most definitely will. This concludes tonight's meeting. Thank you.